Hi, this is Shivaraman from Johns Hopkins University. Now, over the course of this lecture, I'm going to talk a little bit about inflammatory disorders of the small bowel. Now, we're going to begin with a brief introduction to enterography technique and some of the different protocol options that you might utilize in your own practice. But I'm going to concentrate mostly on pathology, and specifically three major categories of small bowel inflammatory pathology that I think come up relatively frequently in clinical practice. Now, we're going to start by talking about the most common inflammatory disorder of the small bowel that any of us confront in daily practice, and that's infection. We'll then move on and talk about a number of vascular disorders which are probably more rare, not things you see on a daily basis, but nevertheless critical to recognize because of their associated morbidity and mortality. And then finally, we'll end with another relatively common category of disease, and that's inflammatory bowel disease, and specifically Crohn's disease. Now, it is worth saying, as a brief introduction, that there is no perfect modality for evaluating the small bowel. Yes, there are some forms of capsule endoscopy can visualize the entire small bowel, but the more you talk to the gastroenterologist, the more you realize that this is a modality that fundamentally lacks some degree of sensitivity. Now, endoscopy is great if you can see the small bowel, but unfortunately, it's pretty limited in terms of how much of the small bowel you can see. And even though there are forms of endoscopy now, so-called push enteroscopy or push endoscopy, that can see farther into the small bowel than ever before, at the end of the day, you're still not going to be able to see the entire small bowel, and it's a limited modality. Now, from a radiologic perspective, all of us have done fluoroscopic small bowel follow-throughs. Some of us have done enteroclysis. But I think we all recognize that this is a time-consuming modality. Increasingly, there's fewer and fewer of us who feel comfortable doing the studies well. And interpreting the studies is still a diagnostic challenge. On top of that, it is a fundamentally limited modality in that it's only going to show you the mucosal surface of the bowel, and it's really not going to give you much information about what else is going on in the abdomen and pelvis. So putting all of that together, I think there's very little doubt that today, at our current stage of evolution in radiology, CT enterography is the best available modality to evaluate the small bowel. Now, how exactly do we do CT enterography studies at Hopkins? First of all, it is critical that the patient not ingest anything for at least 4 to 6 hours prior to the study. You don't want food or particulate matter potentially being confused for a mass or some kind of a neoplasm. Just as importantly, you do not ever want to use a positive oral contrast agent. Positive agents will create beam hardening and streak artifact that will undoubtedly obscure the adjacent bowel wall. And if you're trying to make subtle judgments as to the presence or absence of a small bowel mass, or alternatively, the presence of abnormal bowel wall enhancement, that can be very difficult in the presence of a positive agent. Alternatively, I think what most people use nowadays is a neutral agent. Now, you have a number of different options: water, polyethylene glycol, volumen. And I'd say that the agent that most people around the country are using is going to be volumen, which is 0.1% weight per volume barium sulfate. It's a neutral agent that has a Hounsfield attenuation of about 20, and so it's going to look hypodense. It's going to distend the bowel well and give you maximal distension, but by the same token, still allow you to look at the bowel wall to judge abnormalities both in thickness and enhancement. Just as importantly, this is one application, CT enterography, where 3D post-processing can be very helpful, especially for looking at global abnormalities in the bowel. Volumen, unlike positive agents, is not going to interfere with your 3D post-processing. Now, I will say that even though volumen is probably the most common agent being used nationally, there are many institutions that have now moved completely to water. And that is certainly an option. You're probably going to get slightly better distension with volumen, but I think there will be people who will argue with me about that. Now, here's a good protocol that has been in place at Hopkins for our CT enterography protocols. And you can see that there's administration of 450 cc's of volumen in 3 separate boluses: 60, 40, 20 minutes prior to scanning. And then you give the patient 500 cc's of water immediately prior to the scan to distend the stomach and the proximal duodenum. Now, these studies should be done dual phase. So, of course, you have to give IV contrast, and you're optimally going to acquire both arterial and venous phase images, typically at about 30 to 35 seconds and 50 to 60 seconds, respectively. There are some institutions, decreasingly few nowadays, but there are still some institutions that may give medications, whether it's metoclopramide to stimulate gastric emptying or glucagon to reduce small bowel peristalsis. Honestly, we do not do this any longer at Hopkins. We do not feel these are necessary, especially if you have a fast scanner that is going to pretty much freeze motion, this should not be an issue. Now, let's start now by talking about our first major category of small bowel inflammatory disease, and that's infection. Now, small bowel infections are a very common cause of diarrheal illness in the United States, and as you'd expect, the vast majority are not imaged with CT, right? Most patients aren't even going to come to medical attention. They're going to end up with diarrhea at home. They're going to get better over the course of a few days. Now, small bowel infections can be viral, bacterial, or protozoal, and each of these different pathogens can have different clinical manifestations, but unfortunately it can be very difficult from a CT perspective trying to figure out which organism you're dealing with. And in most cases, we can't be very specific. But I would say regardless of the agent, of the pathogen, small bowel infection is probably the most common cause of small bowel wall thickening that we see in a day in, day out, in day-to-day practice. Now, as I mentioned, the imaging findings for infection are not specific. You're going to get variable degrees of wall thickening, hyperemia, mesenteric inflammation, and ascites, and that can be variable not only between one infection and another, or one organism and another, but even between patients. Two patients can have the exact same organism and can have very different CT findings. Now, the one thing I would say, however, is that regardless of the type of pathogen that you've been infected with, your bowel wall should enhance normally. So if you see bowel wall hypoenhancement, that is typically not an infection, but should at least raise the possibility that you're dealing with ischemia. Now, the one exception to that is CMV enteritis, which can rarely cause mucosal hypoenhancement and can look a lot like bowel ischemia. Now, as I mentioned earlier, typically you can't make a diagnosis of a specific organism based on a CT scan, but there are instances where the distribution can theoretically be suggestive of an organism. For example, Giardia tends to involve the proximal small bowel, and that's a classic finding we all learned when we were trying to learn fluoro as residents. On the other hand, pathogens like TB, Salmonella, Yersinia, Shigella, Campylobacter, typhoid tend to have involvement of the cecum and the distal small bowel. Now, small bowel infection, I'd say in most cases should be on your differential when you're dealing with small bowel wall thickening, and that's particularly true when you have a patient who's immunocompromised or HIV positive. And in those cases, you're probably dealing with an atypical organism, things like MAI, CMV, Cryptosporidium. Now, one organism that I just want to mention because I think it's underappreciated in the small bowel is C. difficile enteritis. Now, we all know about C. difficile colitis, typically in patients who are on antibiotics or chemotherapy and end up with a superinfection. Now, C. difficile can also affect the small bowel as well. It affects the exact same patient population, and it very much looks similar to C. difficile colitis. There's the same predisposition for severe wall thickening and edema, and lots of fat stranding, ascites, and inflammation throughout the abdomen. Now, as I mentioned, most of the time, you're not going to be able to make a specific diagnosis as to an organism, and honestly, there are some situations where infection is just going to have to be one of a number of possibilities in your differential diagnosis. This is a patient with severe infectious enteritis, but I could certainly see other possibilities that you might want to include in your differential depending on the patient's clinical history. Here's another example. Again, severe wall thickening, lots of edema. This turned out to actually be C. difficile enteritis. Now, sometimes the patient's history can be quite helpful. This is a patient with HIV, and you can see that the wall of the entire small bowel is severely thickened, and this actually persisted over several scans, and this turned out to be chronic MAI infection. Now, here's an example of a patient who has a cone-like cecum that's thickened, and you can also see there's thickening of the distal ileum extending into the ileocecal valve. Remember what I said earlier. That distribution of involvement is usually seen with a small number of organisms, and this turned out to be TB of the cecum and distal small bowel. Here's another example, looks very similar. This was actually a patient who had traveled abroad. There's thickening of the cecum and terminal ileum, and this turned out to be typhoid. And based on the distribution, our resident was able to nicely offer this as a leading possibility given the patient's history. So let's move on next to our second major category of small bowel inflammatory disorders, and those are vascular disorders. Now, as I mentioned earlier, these are relatively rare. These are not diagnoses that I'm going to make on a daily basis, but nevertheless, each of these are critical diagnoses because they are associated with, potentially, with very poor patient outcomes. Now, all of these are important, but I want to spend a little time really going into detail about acute mesenteric ischemia, or bowel ischemia, because it is the one diagnosis that I think all of us who do much body imaging are worried about in the acute setting. This is not a diagnosis you want to miss, because a misdiagnosis can really lead the patient to have significant problems. Mesenteric ischemia can be broadly divided into 4 forms. And these 4 forms are based on the cause: arterial occlusion, venous occlusion, non-occlusive mesenteric ischemia, also known as NOMI, and then finally, bowel ischemia on the basis of complicated or strangulated small bowel obstructions. Now, the most common, at least in theory, is bowel ischemia on the basis of arterial occlusion, which, if you look at different sources in literature, probably comprises about 2/3 of all cases. Now, this is typically an embolic phenomenon. The most common etiology is in the setting of atrial fibrillation, but there are really a number of different underlying causes: recent MI, aneurysms, ulcerated atherosclerotic plaque in the aorta, and these emboli usually can go to the SMA, and classically will lodge in the proximal 10 centimeters of the SMA because of the angle of inclination, but you can theoretically end up with smaller emboli that go out distally into SMA branches. If you end up with a big embolus in the proximal SMA, of course your entire SMA territory will be involved. But if you end up with a smaller embolus, it is not that uncommon for just a short segment of small bowel or a small portion of the SMA distribution to be involved. Now, even though this is typically embolic, it is possible for it to be thrombotic as well, and these are patients typically with advanced atherosclerosis or an underlying hypercoagulability syndrome. Now, much less common than arterial occlusion is venous occlusion, which accounts for no more than about 10% of cases and is usually on the basis of thrombosis of the SMV. Now, I'd actually say that in my particular practice, the most common cause is post-surgical. So patients who have had complex have had biliary surgeries or Whipple procedures and are therefore at risk for some kind of SMV thrombosis on the basis of either post-surgical hypercoagulability or because they've had a complex venous interposition graft, jump graft, something along those lines. But that being said, if you look at all comers out in the community, probably you're going to see patients who either have a known hypercoagulability syndrome or a hypercoagulability syndrome that's discovered once they present to the hospital. We also will see a fair number of these cases in patients who have a GI tract infection, like appendicitis or diverticulitis, and develop secondary septic thrombophlebitis of the mesenteric veins. Now, unlike arterial occlusion-related mesenteric ischemia that has a fulminant presentation, these patients often will have a much more indolent and less severe presentation, often subacute, and so even though their presentation may not be as bad, unfortunately, they tend to actually not come to clinical attention as soon as you'd like, and so the mortality rate is actually quite significant, oftentimes in the order of about 40%. Now, the third category is non-occlusive mesenteric ischemia, which you'll hear people abbreviate as NOMI. Now, if you look at the literature, they say it's about a quarter of all cases. An attending I respect a great deal actually thinks that this is a massive underestimate. And he told me recently he thought this is by far the most common cause, but it's just that we don't recognize it because often the findings are nonspecific. But non-occlusive mesenteric ischemia, regardless of how often it occurs, typically occurs in the setting of patients who are ill, acutely sick, and end up with hypotension with resultant diminished blood flow to the small bowel. And so you can think of all kinds of situations where this could happen: cardiogenic shock, massive MI, severe hypovolemia, renal failure with over-diuresis, vasoconstriction because you're on any one of a number of drugs like digitalis or cocaine. So these patients are intrinsically sick, they're intrinsically doing very poorly, and on top of that, they develop bowel ischemia, so it's not that surprising that their mortality rates are quite significant, maybe in the order of 70%, and a lot of that reflects their global healthcare issues rather than the bowel ischemia itself. The final category is complicated bowel obstructions, which again, I think is an underrated and probably underreported cause of bowel ischemia. Now, these are typically not your run-of-the-mill bowel obstructions that are sitting on a medicine service, and they come in with kind of a subacute or relatively non-severe presentation. These are patients who have complicated bowel obstructions, a closed loop obstruction, an internal hernia, a so-called strangulated obstruction, and it's usually not a diagnostic dilemma that it's a big deal. They have acute, severe, fulminant presentations. And the key for you as a radiologist is to figure out who has a simple small bowel obstruction, which is going to be treated conservatively, and who has one of these complicated SBOs that have superimposed ischemia and which typically need to go to the operating room. Now, I think all too often when we're talking about bowel ischemia, we're very simplistic, right? We kind of equate bowel wall thickening with ischemia, and anytime we see bowel wall thickening, we kind of throw ischemia into the differential without thinking about it too much. Okay, there's bowel wall thickening, so it could be ischemia, it could be infectious, it could be inflammatory. And honestly, that is not very useful in terms of your in terms of your dictation. That doesn't really help the clinician very much. So I think it's worth remembering that different types of bowel ischemia or different etiologies of bowel ischemia can present with very different imaging findings. Now, I'm not going to claim that these are mutually exclusive. There is certainly going to be overlap. But in general, different causes of bowel ischemia will often result in different CT findings. So the first is going to be arterial occlusion. Now, arterial occlusion is interesting in that even though we often will associate bowel wall thickening and ischemia in our own minds as radiologists, this is the most common cause of bowel ischemia, and it does not typically cause bowel wall thickening. In fact, the bowel wall will actually thin over time as it infarcts, and the bowel wall will be hypoenhancing. And it's that hypoenhancement that's the key to the diagnosis, and it's often going to be most evident on the arterial phase imaging. Now, just as importantly, there's often very little inflammation. No stranding, no hemorrhage, no edema in the mesentery. Often the only clue to this diagnosis is just that subtle bowel wall hypoenhancement, and I find often that's easiest to identify in the coronal images where you're able to compare different portions of the bowel and figure out which portions are normally enhancing and which areas are abnormally hypoenhancing. Needless to say, tough diagnosis, and when I've seen missed cases of bowel ischemia, they're almost always on the basis of an arterial occlusion, especially when there's not any big embolus sitting in the SMA that clues you into the diagnosis. Now, venous occlusion, on the other hand, much more obvious, right? In these cases, the bowel findings are pretty obvious. The bowel wall is really thickened. It can look hyperdense as a result of intramural hemorrhage or hypodense as a result of edema. The mucosa is often avidly hyperemic, and you're going to see lots of mesenteric findings, stranding, edema, hemorrhage. The bowel can dilate even in the absence of true infarction, unlike arterial occlusion. Now, the mistake in venous occlusion cases is not that you miss the bowel findings, but rather that you don't identify the SMV thrombus, and instead of coming down hard on the diagnosis of a venous occlusion-related ischemia, you instead raise the possibility of infection, or you give kind of a wishy-washy differential. Now, non-occlusive mesenteric ischemia does not have a consistent imaging pattern. It can look like anything. It can look like an arterial occlusion, a venous occlusion, non-specific bowel wall thickening. Just based on the imaging alone, NOMI is actually a tough diagnosis, but it's actually not that difficult to diagnose if you take the time to look at the patient's history. These are not patients who are, sitting at home asymptomatic and come in with some mild symptoms. These are patients in the ICU, they've had an MI, they've had some kind of cardiogenic, they're in shock. They have severe symptoms, and if you know those symptoms and you know their clinical history, then you can often come down on the right diagnosis. And then finally, complicated small bowel obstructions can have features of both arterial and venous occlusion. Remember, these are bowel obstructions where the arterial and the venous blood supply to that segment of bowel is strangulated and obstructed. And so you may see some loops that look like a venous occlusion, lots of bowel wall thickening, mucosal hyperemia, and you may see other bowel loops that look more like an arterial occlusion with no bowel wall thickening and relative arterial wall hypoenhancement. So here's a great example of a patient who has diffusely ischemic bowel. And this can be tricky, and I showed this to a couple of residents, and they struggled because it's globally abnormal. And oftentimes it can be very difficult to figure out the absence of a finding rather than a positive finding. In this case, what you're looking for is the absence of enhancement. Notice how none of this bowel is enhancing at all. There's no mucosal enhancement. The bowel is thickened in some places, but it's not that thick. But notice that one bowel loop blends into another. It's often difficult to identify the wall of the bowel. This is diffusely ischemic bowel, and some people will term this the faceless bowel sign because it's very difficult to distinguish one bowel loop from another because the bowel wall is simply not enhancing. This patient had SMA embolus. Here's another example. Again, the patient has an SMA embolus, and you can see that there are multiple loops of bowel, predominantly in the left hemiabdomen, that are non-enhancing, and you can juxtapose those bowel loops with the more normally enhancing bowel loops in the extreme left upper quadrant. Here's an example of a patient who, again, has an arterial occlusion, and notice that there are some normally enhancing bowel loops, especially in front of the left kidney, but notice that there's a lot of bowel, especially along the lateral aspect of the left abdomen, that's absolutely non-enhancing. Classic bowel ischemia, very difficult to overlook if you're not paying attention to bowel enhancement. Now, here's another example, and you can see that these findings don't always follow the rules 100%. In this case, you can see that this patient does have an SMA embolus, and there's an arterial occlusion. There's a bowel loop more centrally that's clearly hypoenhancing. Maybe there's some pneumatosis, but there's also some bowel loops that are thickened and hyperenhancing. And so even though we try to really draw these discrete categories, I should warn you that there's lots of overlap, and I've seen cases that simply don't follow the rules. Now, over time, arterial occlusion can lead to dilated bowel, and typically that dilated bowel means that you're dealing with transmural infarction. But even in these situations, typically the bowel wall doesn't thicken, but rather it'll actually become thinned over time. And people talk about this as the paper-thin bowel sign. Cases where you don't see that normal bowel wall that's a couple of millimeters thick, but rather there's a complete absence of bowel wall because it's so thinned as a result of that infarction. So here's another case, again, that shows you that there's a lot of ambiguity here, right? Big SMA embolus, and in this case, some of these bowel loops are non-enhancing, but there is some degree of bowel wall thickening. So again, every case doesn't necessarily always follow the rules. So here's an example of a venous occlusion, and notice how the findings here are much more obvious, right? There's clearly an embolus, there's clearly thrombus in the SMV, but notice that these bowel loops look horrible. They're thickened, they're hyperemic, there's lots of mesenteric fat stranding and edema. Not a difficult diagnosis. Everyone is going to notice the abnormal bowel. What people tend to miss is the fact that there is that clot within the SMV. Here's another example. Again, you can see that trilaminar appearance, massive mucosal hyperemia. The bowel looks very thickened, classic example of an SMV thrombosis. Now, the SMV is a very easy place to miss the thrombus, especially when it's short segment. And this is one of the reasons why I do like looking at these cases, looking at the SMV in the coronal plane. I feel like in the axial plane, if you're going quickly through the axial data set, it's very easy to miss a short segment thrombus. That's never going to happen in the coronal plane. Notice in this case, there's extensive thrombosis of the SMV, and a lot of that small bowel in the left hemiabdomen is thickened. It's abnormally hyperenhancing. That's all ischemic bowel on the basis of venous ischemia. Now, as I mentioned earlier, complicated small bowel obstructions tend to have features of both arterial occlusion and venous occlusion. And so there is a lot of overlap in terms of what you can see in any given case. Remember, you're strangulating both the arterial and the venous blood supply. So as in this case, some bowel loops may be abnormally hypoenhancing without a lot of wall thickening, especially in this case, the bowel loops in the right hemiabdomen, whereas other loops may look more like a venous ischemia. They're thickened, hyperemic, as the loops in this case are in the left lower quadrant. You're always going to be on the lookout in these bowel ischemia cases or bowel obstruction cases for features that should suggest it's not just a run-of-the-mill obstruction, but rather that you may be dealing with a complicated obstruction. This is a closed loop obstruction. Notice how these bowel loops are tethered. They're radiating towards a central point. Here's another example, again, of a complicated bowel obstruction. Notice that these bowel loops are abnormally tethered. They're all kind of radiating towards a central point. Notice that, again, the bowel loops are abnormally hypoenhancing. I don't see normal bowel wall enhancement. This is a complicated closed loop bowel obstruction with associated bowel ischemia. Finally, non-occlusive mesenteric ischemia, as I mentioned, doesn't have consistent imaging features. I'd say, honestly, the majority of cases that I've seen have just looked like non-specific bowel wall thickening. Here's a case where I don't think you can come up with a specific diagnosis based on the imaging features alone. There's lots of thickened bowel, but I know for a fact that this patient was in severe septic shock. They were hypotensive. They ended up getting coded in the ICU, and this turned out to be non-occlusive mesenteric ischemia. Now, briefly, it is worth noting that sometimes you can end up with chronically ischemic bowel as a result of a mass in the mesentery involving either the venous or the arterial vasculature. Typically, these patients have more of a chronic presentation, and this tends to be more chronic venous ischemia. Here's an example on the left of a large mesenteric desmoid, and an example on the right of retractile mesenteritis. In both cases, notice that the bowel is massively thickened, it's edematous, and that's probably on the basis of chronic venous ischemia combined with lymphatic or venous obstruction. Now, of course, you don't want to miss the most specific signs of transmural bowel infarction, which is either pneumatosis or portal venous gas. Now, pneumatosis and portal venous gas are both very specific for bowel ischemia, with a specificity approaching 100%. But it is worth noting, even though the specificity approaches 100%, it is not 100%. There are some entities that can mimic bowel ischemia and can cause pneumatosis, or more rarely, portal venous gas. And these tend to be, for example, iatrogenic injuries to the bowel trauma, injuries during a J-tube or a G-tube, or severe inflammatory or infectious disorders of the bowel as well. So it is theoretically possible to end up with pneumatosis, even in cases where you don't have ischemia. Now, I will admit, That is less common with portal venous gas. I've seen lots of cases of pneumatosis where the patient did not have bowel ischemia, but I haven't seen that many cases of portal venous gas without ischemia, although I have seen a few. Now, in most cases, you'd hope that it's an obvious diagnosis like this one, where there's not a lot of ambiguity. There's clearly gas within the wall of the small bowel. In some cases, it's non-dependent, and there's also gas extending out into the mesenteric veins. The one thing I would warn you is you don't want to be the person that's giving everyone pneumatosis. You really want to make sure that that gas is in the wall of the bowel, not simply trapped between fecal material and the wall of the bowel. And so I tend to have a relatively, I try to have a high threshold. When I call pneumatosis, I really want to be certain, and I really want to be certain that that gas is intramural rather than just intraluminal. And as I mentioned, you can end up with pneumatosis even in patients who do not have bowel ischemia, and I'd say the most common cause of that, at least that I've seen in my practice, is patients who have had some kind of iatrogenic injury to the bowel. And the most common that I've seen has actually been patients who have J-tubes. This is a patient who has lots of pneumatosis. There's no free air, there's no portal venous gas. Just based on these images alone, could it be bowel ischemia? Yeah, it could, but this patient was sitting in their room, they were watching TV, they were eating a meal, asymptomatic. They had a J-tube placed about 24 hours before, and this ultimately was all thought to be iatrogenic. So this happens, and frankly, it happens not that uncommonly. So let's move on to our next vascular disorder, and that's acute GI bleeding. Now, acute GI bleeding in the small bowel probably accounts for about 3 to 5% of all GI bleeding cases. And as you can imagine, because we don't have a lot of other good modalities to evaluate the small bowel, this typically goes undiagnosed. Now, small bowel GI bleeding typically can occur as a result of ulcerations, Crohn's, angiodysplasia, vascular malformations. And as I mentioned, both capsule endoscopy and push enteroscopy are limited in their evaluation. And certainly capsule endoscopy is not something you want to be doing in the acute setting. Now, there are some other options, including tagged RBC scans or angiography, but honestly, both of these other options have their limitations in the small bowel. Tagged RBC scans are quite sensitive, but they have poor spatial resolution, and they're not going to allow you to localize the bleeding site with a great deal of accuracy, and they're not going to give you more information about why the patient is bleeding. So if the patient has Crohn's or ischemia or an AVM, that is not information that you're going to get from a nuclear medicine study. Angio is a great modality for treatment, but pretty limited as a diagnostic modality. It can only detect rapid bleeding, about 1 cc per second or greater. It is invasive, it carries risks, and we've all seen complications from angio. And on top of that, it's just relatively limited in terms of its contrast resolution. So when you're doing a non-specific injection, it's very easy to miss a pretty subtle bleed. Now, I would argue that CT angiography is probably now the best modality we have for detecting bleeding, particularly in the small bowel. Pretty sensitive, certainly much more sensitive than angio, and not that much less sensitive than a tagged RBC scan at about 0.35 cc's per minute. And its sensitivity may be as high as 92%. Now, optimally, if you want to catch patients with active extravasation of contrast, you'd like to image them when they're maximally bleeding. Protocols are key here. These are not patients who get the standard enterography protocol. You want to avoid positive oral contrast agents because they will, of course, obscure any sites of active extravasation. Neutral agents, there is some debate. Some will argue that you shouldn't give any neutral agents, whether it's water or volumen, because they potentially could dilute out sites of bleeding and make it more difficult to identify a subtle bleed. Whereas other people will say that you can give neutral agents and that bowel distension is going to help you in terms of identifying the bleed. I don't feel too strongly about neutral agents in this setting. You want to have a brisk injection, typically 4 to 6 cc's of non-iodinated contrast, and it is critical to have at least 2 phases. You want an arterial and venous, or you want non-contrast and post-contrast images. And the reason you need 2 phases is you want to be able to distinguish active extravasation of contrast from intrinsically high-density material in the bowel. Remember, if you have old barium, you have a suture line, maybe a pill or a medication of some kind that you've swallowed, it can look hyperdense, and if you just have a single phase, you're not going to be certain whether or not that's a bleed or just something sitting around in the bowel. But if you have 2 phases, like an arterial and a venous phase, a true bleed is going to change in both size and morphology, so it's not going to be difficult to make that distinction. Non-contrast images work as well. I think they're probably not absolutely necessary, provided that you're requiring arterial and venous phase images, but they can be helpful and they can make it easier because you're just going to be constantly cross-referencing the non-contrast and post-contrast images. Here's an example of an active extravasation in the duodenum. Notice all the hyperdense clots surrounding the site of bleeding. And here's a bleed in the right lower quadrant small bowel. Notice that between the arterial and venous phase images, this bleed is getting bigger. It's changing in morphology. The two features you really want to see in order to differentiate intrinsically high density material from an active bleed. Here's another example. Again, pretty subtle. You have to be quite careful when you're running the small bowel in these cases, but if you look carefully enough, you're going to start catching these, and you can see that there's a small active extravasation in the arterial phase in the upper left, and it's getting bigger and changing in morphology on the venous phase image in the bottom right. So let's talk next about a relatively uncommon diagnosis, but one that I think should at least be in your mind, especially when you're dealing with certain patient groups in the ER, and that's vasculitis. Now, we all know that vasculitis can be broadly divided into three major categories depending on the size of the vessel that's involved. There's large vessel vasculitis, which classically is CTisus and giant cell arteritis. There's medium vessel vasculitis, which includes polyarteritis nodosa, Kawasaki's, primary granulomatous CNS angioitis. And then finally, there's small vessel vasculitis, which is probably the most common type of vasculitis to affect the small bowel, and includes entities like lupus, Henoch-Schönlein purpura, Wegener's, Behçet's, and so on and so forth. Now, the truth is, in most cases, you are not going to be able to make the diagnosis of a specific type of vasculitis based on your CT scan. In most cases, it's going to be good enough if you can at least suggest the possibility of vasculitis when you're confronted with a suggestive imaging study. And what are you looking for? You're looking for findings that are suggestive of ischemia. You're looking for severe wall thickening, massive submucosal edema, mucosal hyperenhancement like you'd see in a venous ischemia case. You may even see a hyperdense wall of the bowel as a result of submucosal hemorrhage. On top of that, you're going to try to find vascular anomalies that support the diagnosis. Mesenteric, renal, or hepatic artery aneurysms are all possibilities that you may see depending on the type of vasculitis you're dealing with, and you may see beading and irregularity of the vessels. The key to this diagnosis is that you want to include it in the differential diagnosis anytime you see horrible looking bowel in a relatively young person. If you see bowel that makes you think this could be the worst case of infection you've ever seen, or the worst, or maybe a horrible case of ischemia, but it's in a patient who doesn't have any risk factors for those entities, think about vasculitis. Young person, horrible looking bowel, think vasculitis, and you can double down on that diagnosis if you see vascular abnormalities, whether it's an aneurysm or beading and irregularity of the vessel, that are going to allow you to make the diagnosis with more specificity. Here's an example of a patient who has horrible looking bowel, lots of ascites, massive mucosal hyperemia. Could this be an infection? Yes. Could this theoretically be venous ischemia? Yes. But this turned out to be a 20-year-old. This is lupus vasculitis. Here's another horrible looking case, really bad looking bowel. And I got to admit, I looked at this case and I thought, this has got to be some kind of ischemia, right? I guess theoretically it could be a really bad infection, but I was worried it was bowel ischemia. But it was a young person, early 20s, so we definitely included the possibility of vasculitis in the differential. And again, this turned out to be lupus vasculitis. Here's another case, very similar, horrible looking bowel, mucosal hyperemia, infections on the differential, ischemia theoretically on the differential, but this is a young person. Actually, I think they were about 10 or 12 years old. This turned out to be Henoch-Schönlein purpura. It's really patient demographics that are critical to making the diagnosis. Now, if you see vascular abnormalities, as in this case, then you can be even more confident about making the correct diagnosis. Notice the beading and irregularity of the mesenteric vasculature. This is not normal. These aren't normal vessels, right? So this is a patient who had CTisus arteritis. I will admit there are going to be some aneurysms and irregularities of the vessels that are going to be difficult to see on CT and are often easier to see on angio. This is a patient who has polyarteritis nodosa. Notice that not only is there a bigger aneurysm proximally in the vessel, every single one of these tiny branch vessels has tiny microaneurysms, and the classic for polyarteritis nodosa. Now, another finding that can help you at least suggest the possibility of vasculitis is thickening of the vessel wall. Now, here's an example where the wall looks thickened. There looks like there's almost this plaque along the lumen along the wall of the SMA, and maybe even along the aorta as well. And it'd be very easy to say, well, that's probably atherosclerotic. But this is a 20-year-old. Why would they have atherosclerotic wall thickening. This is actually inflammatory wall thickening related to polyarteritis nodosa. So you really got to take into account patient demographics. A lot of these findings are non-specific, but if you incorporate the findings along with your clinical history, you really can come to a specific diagnosis in some cases. So let's move on to our next vascular disorder, and that is mesenteric arterial dissection. Now, the vast majority of dissections that you see in the SMA or the celiac are going to be an extension of an aortic dissection. But that being said, isolated visceral artery dissections, even though rare, are being increasingly seen on CT because of our better spatial and temporal resolution. The most commonly affected vessel to have an isolated dissection, in the visceral arteries at least, is the SMA, and you can see them once in a while in the celiac and common hepatic arteries as well. And when you do see an isolated dissection of a visceral artery, these patients are not normal. There almost always is some underlying weakness of the vessel wall, whether it's cystic medial necrosis, fibromuscular dysplasia, collagen vascular disease, or segmental arterial medial lysis. Now, this is an important diagnosis, particularly in the acute setting. And I'll admit, acute mesenteric artery dissections are pretty uncommon to see in clinical practice. And I think I've seen two over the course of the last 2 or 3 years. Here's what you're looking for. You're looking for dissection, of course, but you're looking for stranding, edema, and even hemorrhage around the margins of the affected vessel. In this case, the patient had acute abdominal pain. You can see that there's a dissection. Clearly, there's findings here suggesting acuity given the blurring around the margins of the vessel. And in these kind of cases where you have an acute dissection, you can't just let the patient go home. The patient does need to be seen by either a vascular surgeon or an interventional radiologist. But that being said, I haven't seen that many acute dissections, and the vast majority of dissections that I see are incidental. You see a random dissection in the SMA or the celiac in a patient who's being treated for completely unrelated reasons. And in cases like this, there's always that dilemma. What exactly do you do about it? And the truth is, most of these patients with isolated incidental dissections do not need any kind of an acute treatment. Rather, you do need to follow them over time because some of them can develop aneurysms, and so you probably need to be on the lookout. And you can kind of determine follow-up depending on whether the vessel is aneurysmal at presentation. Let's talk next about another vascular entity that I think most of us don't think of as being vascular, but is fundamentally the result of a vascular anomaly, and that's traumatic shock bowel complex. Now, shock bowel can occur not only in the setting of trauma, but any cause of systemic hypotension. Classically will involve the entire small bowel and will result in severe submucosal edema and massive mucosal enhancement of the entire small bowel. Now, of course, other things could be considered in the differential diagnosis, but it's the clinical history that's really going to guide you to the correct diagnosis, as well as other features of the shock complex that may be ancillary imaging findings. A flattened IVC, narrow aorta, peripancreatic fluid that can look a lot like pancreatitis, hypoenhancement of the spleen and liver, and often intense enhancement of the adrenal glands. Here's a patient after trauma. Notice the slit-like IVC pointed out by the arrow and the diffusely thickened hyperemic bowel, classic shock bowel complex. Here's another example. Again, patient after trauma. Notice the profoundly thickened and hyperenhancing small bowel in the left upper quadrant. Again, a nice case of traumatic shock bowel complex. So let's talk next about another vascular disorder that, again, is another one of these entities that we don't think of as being fundamentally vascular, but is as a result of a vascular anomaly, in this case, radiation enteritis. Now, radiation enteritis you can think of as being a form of vasculitis related to bowel loops being included within the deep pelvis in a radiation port. Now, the vast majority of cases of radiation enteritis that I see in my practice are GYN malignancies, so typically endometrial and cervical cancer, but every once in a while you'll see patients who end up with radiation enteritis after getting brachytherapy beads for prostate cancer. Now, if you don't have a good clinical history, but you do see bowel loops that are affected in a classic distribution, look for signs of prior surgery or treatment. So look for a hysterectomy, look for those brachytherapy beads, findings that can at least suggest that this patient has prior malignancy. Now, the affected bowel loops typically will look a lot like those vasculitis cases I showed earlier, submucosal edema with mucosal hyperenhancement. But the key to making this diagnosis is that the bowel loops are affected in a very specific distribution. Those bowel loops in the radiation port will look abnormal, but they are sharply demarcated from those bowel loops above the radiation field, which are going to look completely normal. Associated with this are often going to be abnormalities of the rectum and bladder, which are also involved, resulting in radiation proctitis and radiation cystitis. So here's a patient who had radiation treatment for cervical cancer. The bowel in the pelvis looks profoundly thickened, it's hyperemic, but I'm not showing you, but the bowel loops above the radiation port look completely normal. This is a classic example of radiation enteritis. Here's another example, again, radiation enteritis after cervical cancer. Notice that not only is the bowel in the small bowel in the deep pelvis involved, but so is the bladder and the rectum. This patient has radiation cystitis. Notice that thickening and inflammation of the bladder. Radiation proctitis. Notice the thickening and inflammation of the rectum. And most importantly, only the small bowel in the pelvis is affected. The more superior small bowel looks completely normal. So why don't we end our discussion of inflammatory bowel diseases by talking about IBD. IBD involving the small bowel, i.e. Crohn's disease. Now, Crohn's disease is a transmural inflammatory bowel disease that affects somewhere in the order of 1.5 million Americans and Europeans. Symptoms, generally nonspecific, laboratory markers, typically not helpful, and so imaging really is the key. And this increasingly is important as we have a number of drugs that can be very efficacious in terms of treating Crohn's disease, so you really do want to identify these patients and make the diagnosis effectively at the earliest stages. Now, there's a lot of data supporting the utility of CT enterography in diagnosing Crohn's disease. It is at least as good as small bowel capsule endoscopy, potentially better, and certainly should be the first modality that you use in a patient who has suspected Crohn's. After all, you do not want to give a capsule to a patient with potential Crohn's disease without knowing whether or not they have a dominant stricture or bowel obstruction, because after all, that'd be the worst thing, right? Giving a capsule endoscopy to a patient who has a dominant stricture, that capsule's not coming out. So always start with CT enterography. Now, Crohn's can affect any part of the GI tract extending from the mouth to the anus. The earliest phases of involvement can be quite subtle, and it's those earliest phases that are best detected using arterial phase images. You may not see much in the way of bowel wall thickening, but often you'll see subtle mucosal hyperemia, and you may see engorgement of the vasa recta and mesenteric vasculature supplying the affected bowel. Now, unfortunately, the earliest phases can be very difficult to detect in the venous phase images because you're not going to see much in the way of bowel wall thickening. Now, later involvement, where you get worsening inflammation, you can make that diagnosis pretty easily whether you're looking at arterial or venous phase images. The bowel is going to look thickened, you may see lots of mucosal hyperemia, and you'll see engorgement of the vasculature feeding those bowel loops. Now remember, patients with Crohn's typically have a classic distribution involving the distal ileum or the terminal ileum, but honestly, any portion of the GI tract can be involved. Here's a great example of that classic distribution, classic appearance of Crohn's disease. Notice the profoundly thickened terminal ileum, massive engorgement of the vasa recta, classic active Crohn's-related inflammation. Here's another example. This patient probably has 30 centimeters of their ileum that looks thickened and inflamed. Clearly, those engorged mesenteric vessels that are so nicely illustrated on the 3D formats suggest that this is active inflammation. Now, one of the reasons I really strongly support getting a CT scan before you try to do any kind of an intervention or giving a capsule endoscopy is you really do want to see if there's evidence of bowel obstruction. Here's a patient who presents with acute abdominal pain, clearly obstructed, lots of dilated bowel loops, and this is an obstruction as a result of a long segment, acute inflammatory stricture of the terminal ileum, probably involving about a 10 to 15 centimeter segment. Now, the findings you're looking for to suggest acute inflammation are not simply in the bowel alone. You do want to look at the mesentery as well, which can be a strong clue that you're dealing with active inflammation. You want to look for engorgement of the vasa recta, mesenteric hyperemia, fat stranding, edema, ascites, all of which are particularly important in cases where the bowel findings are either subtle or equivocal. And it's also worth noting that these vast mesenteric findings can be very important in those cases where your enterography study was suboptimal, you didn't get great distension, and you end up with a bunch of collapsed bowel loops where it's much more difficult to evaluate mucosal enhancement or bowel wall enhancement. Now, as I mentioned earlier, the earliest stages of Crohn's-related inflammation can be virtually invisible on venous phase images, and that's where the arterial phase images can be so helpful. Here's an example where the MIP images nicely illustrate that there's increased vascularity of that right colon and the terminal ileum. There's no bowel wall thickening. I'm not showing you the venous phase, but the venous phase images look pretty normal. But if you look at the vascularity, that can really be a strong clue that you're dealing with early active inflammation. I really like in these cases where I suspect Crohn's disease to always create MIP reconstructions, usually off the coronal arterial phase, because I want to see if there's any areas in the mesentery where there's more flow or more vascularity that may hint at the possibility of very early active inflammation. Now, over time, you may start to see stigmata of chronic inflammation, or in other words, the stigmata of multiple repetitive bouts of inflammation. You may see fat deposition in the wall of the small bowel. You may see fat in the surrounding mesentery, so-called creeping fat. Often you'll see loss of the normal fold pattern. You often will end up with strictures, maybe even frank obstruction. And as I mentioned, it is critical that you let the gastroenterologist know if there's any areas that are potentially strictured, as you want to prevent them from administering capsule endoscopy. Here's an example of chronic intramural fat deposition secondary to multiple repetitive bouts of inflammation. It is worth noting that this is not specific for Crohn's disease. This can be seen with any form of inflammatory bowel disease, and more broadly, any form of bowel inflammation, as well as patients who are either obese or diabetic. So you shouldn't necessarily jump to saying that every patient with intramural fat deposition has occult inflammatory bowel disease. Here's a patient with a long segment of stricturing and wall thickening with proximal bowel obstruction, and admittedly it can be quite difficult using any radiologic modality to figure out whether this is a chronic stricture or alternatively an acute inflammatory stricture. Some people will argue that on MR you might be able to make the distinction based on whether or not you see wall edema on T2 weighted images, but the truth is, regardless of the modality you use, it can be difficult to differentiate acute from chronic strictures. Here's another example. Again, a stricture of the bowel, maybe a little bit of stranding in the adjacent mesentery. We thought that this was probably chronic given the lack of enhancement at the affected site, but the truth is it can be quite difficult. And sometimes you're just going to have to say age indeterminate in terms of the stricture. As I mentioned, you may see chronic findings in the mesentery as well as a result of repetitive bouts of inflammation. Notice in this case, not only is there fat within the wall of the rectum, there's actually creeping fat in the surrounding the rectum. So usually this creeping fat or fibrofatty proliferation is along the anti-mesenteric border of the bowel and results from multiple bouts of active inflammation. And there are actually some people who believe that the fat itself may be hormonally active and may drive the patient's inflammation. Now, once you've identified the inflamed, involved loops of bowel, your job isn't done, right? You want to look for other ancillary features of Crohn's disease and complications. And one of the complications that's critical to identify is the presence of fistulous disease. A third of patients with Crohn's will develop a fistula within a decade of their symptom onset, and by far the most common location is going to be the perianal region. I should warn you, CT is not a good modality for the evaluation of perianal fistula. Goes without saying that if you're concerned about a perianal fistula, you should get an MR. MR is great for this indication and certainly has a lot of advantages in this particular anatomic location for identifying subtle fistula, and more importantly, delineating what type of fistula you're dealing with: suprasphincteric, extrasphincteric, transsphincteric, so on and so forth. But CT is probably as good as it gets in terms of identifying other fistula in the abdominal or pelvic cavity, and so you may see small bowel to small bowel fistula, small bowel to colonic fistula. You may see sinus tracts, and in some cases you may actually see a discrete fistulous tract, but you should always be on the lookout for secondary signs of a fistula, even if you don't see the tract itself. In a patient with Crohn's-related inflammation, if I see multiple small bowel loops that are spiculated, tethered towards a central point, with ectopic gas and fluid at their center, even if I don't see fistulous tracts, I'm going to be worried that the patient could potentially have complex fistulizing Crohn's disease. And here's an example of that. Multiple small bowel loops, they're thickened, they're inflamed in a patient with Crohn's disease. Notice that there's edema and stranding in the center of these bowel loops, and there's actually ectopic gas. Now, I don't see a discrete fistulous tract. I don't see contrast abnormally traversing one bowel loop to another, but the presence of this ectopic gas, the configuration of this bowel loop, makes me very strongly suspicious that this patient does in fact have complex fistulizing disease. Here's another example. Again, I don't see the fistula, but there's a huge phlegmonous collection at the center of several small bowel loops. There's ectopic gas. This patient, even if I don't see the fistulous tract, almost certainly has complex fistulizing disease. If you're lucky, you're going to see something like this: discrete fistulous tracts. Enteroenteric fistulae, I've found, are often easier to identify on coronal reformats, especially using volume rendering or MIP reconstructions. And in cases like this where you really are concerned about a fistula, this is the one exception to my rule of not using positive contrast. Positive contrast can be very helpful in these cases for actually filling the fistulous tract and making them more obvious. Finally, one form of fistulous disease that I think is overlooked a lot is intravesicular fistulas. Now, oftentimes people are hesitant to make this diagnosis unless they see a direct track of contrast or gas going directly from the bowel into the bladder. So they want to see actual intraluminal gas within the bladder to make this diagnosis with confidence. And as far as I'm concerned, that's probably a pretty high threshold for this diagnosis. Most of the intravesicular fistulas that I've seen, there's actually there's not gas in the bladder. And often you don't see a direct tract going from the bladder to the bowel. Instead, I think, again, this is an instance where you can use secondary features to help you make the right diagnosis. When I see a thickened, inflamed bowel in close contiguity to the bladder dome, often directly contacting the bladder dome, and the bladder dome looks thickened immediately at the site of contact, even if I don't see a tract, even if I don't see ectopic gas in the bladder, I'm at least going to raise the possibility that the patient could have an occult intravesicular fistula. So in conclusion, hopefully I've given you a sense for why proper CT technique is absolutely vital in terms of identifying and diagnosing a lot of the small bowel inflammatory and infectious disorders we've talked about during the course of this lecture. If you don't have the right phases of contrast, you're not going to be able to make the diagnosis in many of these cases. Without dual phase imaging, many of the vascular disorders I talked about earlier are virtually impossible to diagnose with any degree of specificity. And just as importantly, if you choose to use positive contrast instead of volumen, you're going to have a hard time really making those subtle determinations regarding abnormal bowel wall thickening or bowel wall enhancement. Secondly, intrinsically, when you're dealing with a small bowel, you have to realize that there's a substantial overlap in the appearance of many of these disorders. And just based on the CT appearance alone, I think in many cases it is not going to be possible to make a specific diagnosis. If you really want to be helpful to your clinician, if you really want to provide a more abbreviated differential diagnosis or even a specific diagnosis, you really do have to look at the patient's clinical history. Clinical history in many of these cases is going to be critical at allowing you to make a specific diagnosis. But even if you can't make a specific diagnosis, there's nothing wrong with providing a useful short differential diagnosis. But you don't want to be one of those guys who, anytime you see bowel wall thickening, you say it could be infectious, inflammatory, or ischemic. That's not useful. Provide a useful differential diagnosis based on the clinical history. Finally, I got to tell you, when I'm looking at the small bowel and I see abnormal small bowel, the thing I'm always worried about is bowel ischemia. This is probably the most vital diagnosis not to miss of all of the things we talked about during the course of this lecture. So anytime you see abnormal bowel, at least think about bowel ischemia and consider whether there's any features that might suggest that diagnosis. So that's all I have. I'll see you guys later. Thanks again. Bye.